all of you, those online and here in person. Quick note for those of you online, if you'd like to ask a question of Professor Engelhard, that function at any time. We will collect these questions until the Q&A period begins. We'll get to as many questions as we can. Now I'd like to introduce Professor Carolyn Engelhard. Professor Engelhard directs the Health Policy Program in the Department of Public Health Sciences. Holds the position as Associate Director of the Center for Health Policy. Professor Engelhard's academic activities include analyzing and monitoring changes in health policy at the federal and state government levels, and teaching in both Graduate School of Arts and Sciences and the School of Medicine. Professor Engelhard co-authored a book looking at the myths surrounding the U.S. healthcare system, completed a national project in conjunction with the nonpartisan Urban Institute, examining the use of public policies to reduce, distributed a textbook chapter examining the effect of the new law on healthcare organizations. Professor Engelhard co-directs a national webinar featuring health policy experts and students across 4 universities each spring, and she's a contributing health policy expert for the web.
Thank you. Good morning, everybody. I would like to thank the Focused Ultrasound Foundation for inviting me here today, and I'd like to thank all of you for attending this webinar. The title of today's topic is the Affordable Care Act, Promises, Perils, and Politics. And before I begin, as I do with all of my presentations, I am disclosing that I have no financial conflicts of interest. So I have about 17 slides. This is a pretty complicated topic. I suspect this will go for about an hour, and then I encourage all of you to send in questions. I know we can't have a one-on-one discussion this way, but I'd like to think that at least I can answer some questions that you might have. Okay, so let me start. This is the way I start every single class that I teach at the University of Virginia, with this triangle that I call sort of the holy trinity of health policy. Because when we talk about healthcare policy, usually we're talking about certain aspects of our healthcare system that have to do with who has health coverage, how much healthcare costs, and then how do we measure the quality of it. I'm going to narrow that focus today and talk about that in relation to the Affordable Care Act, which was signed into law by President Obama in March of 2010, has a very long name, the Patient Protection and Affordable Care Act, which we abbreviate as the ACA, the Affordable Care Act. And really, the law had 3 goals. One was to address what had been and continues to be a problem with Americans not having access to health coverage, but also the spiraling growth in healthcare spending over the last 50 years, as well as improvements in quality. The goal of the ACA was to look at each of those points and to ensure 30 million additional people over 10 years. So this is a slide that looks at the mechanisms of health care coverage. Now, when we talk about health care coverage, what we're really talking about is how do people pay for the medical care that they seek? Typically, it's some kind of insurance. So if you're over the age of 65, you have Medicare. If you are certain poor people, you have Medicaid. And most Americans have it through their workplace. 160 Americans get health coverage through their jobs. So the Affordable Care Act tried to address the gaps in our current health coverage system. When the ACA was passed in 2010, there were 45 million people without health coverage, without some sort of health insurance. And so a big thrust of the ACA was to set up mechanisms so that people could get health care coverage in various ways. So I'm going to walk you through those mechanisms. The first one is marketplaces. These are also called health insurance exchanges, and during this webinar, I'll probably be referring to them as exchanges because that's how the statute referred to them. It's interesting, sort of just one little factoid, the reason that Health and Human Services changed the name from exchange to marketplace was because there was not an easily translatable term for exchange in Spanish, and they wanted to appeal to Spanish-speaking folks who were uninsured, so they changed it to marketplaces. But if you hear those terms, they're interchangeable. So what do we mean by these marketplaces? Well, these marketplaces or exchanges provide a mechanism for health insurance companies to come and sell their plans to individuals. Now, the Affordable Care Act regulates those insurance companies such that they could no longer turn people away for pre-existing conditions. They could no longer charge women more than men. They could only preferentially treat premiums differently for two reasons. One was tobacco use, and the second one had to do with age. And so someone older could be charged no more than 3 times someone younger. So it really changed the way insurance worked in this country for individuals because it allowed everyone the promise of being able to get health insurance. So these exchanges had competing plans on them. People would receive a subsidy to help them buy insurance if their income was between 100 and 400% of the federal poverty level. What does that mean? 100% of the federal poverty level is about $12,000. 400% of the federal poverty level for an individual is about $45,000. So folks between $12,000 and $45,000 for an individual, if they didn't have health insurance through their job or through some other program, they could go to these marketplaces or these exchanges and purchase a health insurance plan using those subsidies. The second mechanism under the ACA to expand coverage was through the Medicaid program. Many of you out there may not know that our Medicaid program in the U.S. is what we call a categorical program, and that is it covers certain categories of people. It covers poor children, poor pregnant women, the disabled, and frail elderly who are low income. If you are a childless adult, you could be penniless. You could live under a bridge, on a grate, and unless you were declared disabled, you would not be eligible for Medicaid. Most Americans, I think, believe that people who have no money can get health care through a government program, but that's really not true. If you need health care and you're uninsured and you have no money, you can walk into the emergency room and they will treat you. But there is no health coverage that is designated for you. So under the ACA, because so many of the 40+ million people who were uninsured were childless adults under the age of 65 who were what we might call the working poor, they allowed under the statute for folks up to 138% of the federal poverty level to become eligible for Medicaid. That's the way the statute was written. As you can see on the slide, that's about $16,000 for one person or $33,000 for a family of 4. Hold that thought because in my next slide I'm going to tell you how this changed. But originally this is the way the statute was written, so that this one then would pick up a fair number of people who had been uninsured before and who did not fit into those traditional categories under Medicaid. The next category are employers. As I mentioned before, 160 million Americans receive health insurance through their jobs. The ACA didn't want to disrupt the employer-sponsored insurance market, but they did want to make it more consistent. So employers with more than 50 employees under the ACA are required to provide what are called qualified health coverage to their employees or pay a penalty. That went into effect For larger companies, January 1 of 2015, and for smaller companies, it goes into effect this January, so January 1st, 2016. For companies with 50 or fewer employees, they are not bound by this mandate. So the next coverage mechanism on our wheel, if you will, are young adults under their parents' insurance. Before the ACA, most young adults, when they graduated from college, aged off of their parents' insurance plans. And in fact, the largest cohort of the uninsured were the young adults. The ACA allows up to 26-year-olds to stay on their parents' health insurance plans, and since it has rolled out since 2010, up to 6 million young adults have been on their parents' plan because of the ACA. This is a very popular attribute of the Affordable Care Act, unlike some of the other pieces of it. And then finally, this direct enrollment. So for people who don't get their health coverage through their jobs and aren't eligible for a government program and don't qualify for a subsidy on the exchanges, those folks are able to purchase individual health insurance with the same consumer protections found on the health insurance exchanges. So that would include no pre-existing condition exclusions, not being charged a different rate because of your sex or your age, except for a slight variation, and so on. So this made up the coverage mechanisms of the ACA, and it was all tied together by the individual mandate, which is probably the least popular attribute of the Affordable Care Act. But if you think about it, it's really necessary, because if you enforce a requirement on insurance companies to take all comers, regardless of how sick they are, and you tell them they can't drop them, and you can't charge certain people more than other people, then why would anyone buy health insurance until they got sick? And if they waited and only bought it when they got sick, then your insurance pool would be filled with nothing but sick people, which is called adverse selection. The way insurance works, whether it's health insurance or auto insurance or homeowners insurance, is to get a large risk pool where most people are actually not using the service. And so by getting more healthy people into a health insurance pool, you're able to keep the premiums more stable. And because of that, they require all people to have health insurance or pay a penalty. So that is the basic structure of the Affordable Care Act. So let's move on. I want to give you a little bit of history because it's really, it's very interesting when we talk about the politics surrounding the Affordable Care Act. The Affordable Care Act is the only piece of social legislation in the history of the United States, major social legislation, think of Medicare, Medicaid, Social Security, that did not garner one vote from the opposing party when it made its way through Congress. By definition, that meant that the Affordable Care Act would be politically very volatile, and it has been, and these 4 near-death experiences just indicate that more. So let me walk you through them very quickly. The first one has to do with actually the passage of the ACA. So I want you to go back and remember your civics class in high school and remember how a bill is actually passed in the United States. So the way it works is that a bill is introduced in the House of Representatives and a companion bill is introduced in the Senate. Each body votes on that bill, and then it goes into what's called a conference committee, at which time the 2 bills that are similar but different, because the House of Representatives is a very different body than the U.S. Senate, they come together, the conferees come together, and they merge the bill into one bill, and then that bill goes back to each chamber, is voted on, and then goes up for the President's signature. With the Affordable Care Act, the House of Representatives bill was passed in the summer of 2009. And on Christmas Eve day of 2009, the Senate passed its version. I think I'm probably the only American other than the legislators who was actually watching that on C-SPAN on Christmas Eve morning, 2009. Everybody then, as I said before, not one Republican vote. Everybody went off for Christmas break. They came back in January. They went into conference committee, and something happened. So in order for a bill to pass in the U.S. Senate, you have to have 60 votes to avoid a filibuster. Senator Ted Kennedy had died the previous August and was a real champion for health care reform, if you want to call it that. When he died in August, the governor of Massachusetts appointed a temporary stand-in who was a Democrat, and that kept the 60th vote in the Senate. In January, when the two bills were being reconciled in conference committee, there was a special election held in Massachusetts for the empty seat of Senator Kennedy, and for the first time in 35 years, a Republican, Scott Brown, was elected. That deprived the Senate of the 60 votes. And so it would have been, everyone thought, those of us who watched this professionally, thought, well, this is it. This is the last chance. I mean, it's not the last chance, but it's the next attempt that was unsuccessful. There's been many attempts in the last 100 years. Well, because of some sort of legislative maneuvering, the House of Representatives ultimately passed the Senate version of the bill, which meant that both chambers passed the same bill, and then it went up to the President for his signature. This has had some unintended consequences that I will talk about in a few minutes. But that was the first near-death experience for the ACA. The day after the ACA was passed, in March of 2010, Attorney General Ken Cuccinelli in Virginia filed a suit claiming that the ACA was unconstitutional. And shortly thereafter, 25 other states' Attorney General filed a class action suit challenging the ACA on its constitutionality. It went through the various courts, the various cases went through the various levels of the court, and ended up in the Supreme Court in the summer. Well, actually, oral arguments were in March of 2012, exactly 2 years after the passage of the ACA. In the summer of 2012, in late June, the Supreme Court ruled 5-4 in favor of upholding the ACA, saying that the individual mandate was constitutional, but that the states could not be compelled to expand their Medicaid program. That clearly it was fine, according to the Supreme Court, for the federal government to provide incentives in the form of financial incentives or other kinds of incentives for states to expand their Medicaid programs, but that they could not be forced to do so. So that was the second near-death experience. The third near-death experience came in November 2012 during the presidential election. Many Republican governors and conservative states had been holding out for this election, hoping that Mitt Romney would win and that the Senate would ride his coattails and become Republican. The House of Representatives had already flipped to majority of Republicans during the midterm elections of 2010. And so there was great hope among conservatives that if Mitt Romney won and the Senate went Republican, they would have a Republican president, both houses Republican, and that they would just be able to repeal and defund the Affordable Care Act. But as we know, President Obama was reelected. The Senate held its slight majority in 2012. Of course, that changed in 2014. But that was the third near-death experience. The final near-death experience, at least so far, just happened recently, this year. Once again, a challenge was brought before the Supreme Court that had to do with the language of the ACA. There were 4 words in this 1,000-page bill and those 4 words were established by the state. And it had to do with these tax credits or these subsidies that were afforded people on the exchanges in order to buy health insurance. The plaintiffs contended that because the statute said that these tax credits would be available to those who enrolled on exchanges of the state-based exchanges, they made the point before the Supreme Court that a literal translation of that would be that anyone who signed up on the federal exchange, so states were encouraged to set up their own exchanges, but if they did not, under the law, they would default to a federal exchange. So the plaintiffs argued that only those who had signed up under the state-based exchanges should be eligible for tax credits. Many, many fewer states set up their own exchange. I have more about this coming up. It involved about 7 million people who were enrolled under the exchanges whose insurance would have been essentially taken away if the Supreme Court had gone with the plaintiffs. So established by the state was the 4 words, and the Supreme Court once again found in favor of the ACA, this time in a 6-3 ruling to maintain the tax credit subsidies in the federal exchanges. So that's a little bit of the history. It follows. I mentioned earlier what a contentious bill this was, how it had no bipartisan support, and you can see that since its passage, the politics has continued to dog it, which has had a lot to do with its implementation or lack thereof. Okay, so where are we now? Let's review. So health insurance exchanges, there are 13 plus the District of Columbia that are state-run exchanges. 34 use the federal exchange. In the first year, there was a few more than 6 million who signed up on the exchanges. And then last year, 9.1 million. That's not 9.1 new. It's a rolling tally. So it's a net gain of 3 million. And of those, 9 out of 10 received a subsidy to purchase health insurance. The Medicaid expansion, 30 states plus the District of Columbia have expanded their Medicaid program. 14 million new sign-ups. You can see much greater increase in Medicaid sign-ups in those expanding, obviously, than in non-expanding. 72 million Americans are now in Medicaid, 1 in 5. And of those states not expanding. So this is a little bit difficult, so hang in there with me while I explain this. So as I mentioned before, every policy has intended consequences and unintended consequences. When the Supreme Court made the Medicaid expansion program optional, an unintended consequence was that there would be people who were actually too poor for subsidies. So remember, I told you that on these exchanges, folks with incomes between 100% of the federal poverty level and 400% of the federal poverty level received sliding scale vouchers or subsidies to purchase health insurance. If you were under 100%, under the statute, initially you would have been covered under the Medicaid expansion. For those states who chose not to expand their Medicaid program, that meant that the families and individuals under 100% of the federal poverty level would be ineligible for subsidies and would not be eligible for a Medicaid expansion that states opted out of. So let me give you an example. I'm a mom with 2 kids, and I make $15,000 a year. My 2 kids are covered under the traditional Medicaid program. I make less than 100% of the federal poverty level for a family of 3. Therefore, I'm uninsured, but I can't go to the exchange and receive a subsidy to get help to buy health insurance. My neighbor, who is a mom with 2 kids, makes $26,000. Her kids are also eligible under the Medicaid program, but she has a family income over 100% of the federal poverty level, so she can go to the exchange and receive a generous subsidy to help her buy health insurance. So it is an unintended consequence whereby poorer people are left out. They're left in this coverage gap, of which there are 4 million nationally, and in Virginia, for those of you who are Virginia citizens, as I am, there are about 180,000 Virginians who fall into this coverage gap. So as far as compliance goes, last year, 7.5 million Americans chose to pay the penalty rather than have insurance coverage. So that's sort of where we are. Enrollment for next year begins Sunday, day after tomorrow, and goes through the end of January. So a question I think one should ask is the ACA working? It costs a lot of money, $1 trillion over 10 years, $100 billion a year. How do we know if it's working? We know that it's very unpopular with some people, and we hear sound bites on TV all the time. But how do we know if it's actually accomplishing its goals? Remember my triangle of coverage, cost, and quality. So let's look at coverage. So you can see by this graph that 80% of Americans experience no coverage change. As I mentioned earlier, most of us get health insurance where we work. And for those folks, very little changed. Over half of the uninsured reductions, those who became insured, did so through the Medicaid expansion in those 30 states that expanded their Medicaid programs. The uninsurance rate went down over 50% in those states that expanded their Medicaid program, and about a third in the states that did not expand. So since the ACA rolled out its exchanges and the Medicaid expansion, January 1 in 2014, there was a net gain of 17 million people. So 17 million Americans now have health coverage who did not have it before 2014, and the national uninsured rate went from 18% to about 11%. That is a huge jump historically for this country. So we can argue about how much it cost and other parts about the law, but it was able to insure folks who heretofore had not had insurance. Okay, what about spending? So this graph looks at the growth in health spending. We spend $3 trillion a year in our healthcare system, 18% of our gross domestic product. We spend 2.5 times more than our closest peer country in Europe. And the rate at which the healthcare spending grows has outpaced general inflation for 30 years. It's a big deal to economists and health policy experts because at the rate that our health spending is growing, we will soon squeeze out other goods and services in our economy. So this graph looks at the growth, and you will see that since the ACA came in, it looks like growth in health spending has really dropped. In 2013, the growth was the slowest it had been in 50 years. And in fact, Medicare spending per beneficiary in 2013 was $1,200 less than predicted just 3 years earlier. As you can imagine, the Obama administration wanted to take credit for that, say it was because of the ACA, but other experts suggested that it probably had more to do with the recession. We know that when there's an economic recession, people buy less of everything, including health care. There was also the Budget Control Act called the Sequester, which cut Medicare reimbursements. The fastest rising health insurance type of health insurance is a high deductible health plan. We know that when you ask people to pick up more cost sharing, they use less health care. So it was unclear just how much we could attribute this downward trend to the ACA. But then we got the data from last year. And what we saw was when the economy grew, so did health spending. Health spending jumped to 5.5% in 2014, and it's predicted to grow at that rate or a little bit more through the next decade. That would suggest that the ACA so far has had a limited impact on reducing health spending. So our third point has to do with quality. Quality is one of those things that most Americans don't understand very well. Most Americans think you go to a doctor, you go to a hospital, and it's always quality health care. But those of us who track this, who look at this, know that that is not true. There's huge variation in quality among hospitals, among physicians. And because of that, the federal government started assessing quality metrics to measure outcomes, as well as having penalties for certain quality lapses. So this is a chart. I know it looks like gobbledygook, but it basically talks about the changes in central line infections. That's the top one. Catheter-associated UTIs, pressure ulcers. These are clinical presentations that are associated with preventable adverse events. And the AHRQ, Agency for Healthcare Research and Quality, reported not quite a year ago that things have really improved. 17% cumulative reduction preventing 50,000 deaths. So that's good news, right? Well, it is good news, and there are reasons for that. Some of it has to do with the public reporting, better sharing of best practices. But the bad news is that these performance measurements, these quality metrics, are all over the map. If you are a hospital or a physician that is under contract with various public and private payers, you can have totally different quality metrics. Some of them can be contradictory with each other. Most of them lack well-defined studies. So the bottom line is that physicians are increasingly tired, suffering from measurement fatigue. Here at UVA Hospital, I work in the School of Medicine, but the hospital has to report over 400 quality measures every year. And yet we still have continuing system problems like misdiagnoses, overdiagnoses, and unnecessary procedures. So I think, the scorecard is we've made some progress, but we have a ways to go. So for any of you out there working in hospitals, the ACA promised hospitals that they would relieve their pressures and asked hospitals in the very beginning to help pay for the ACA, much as they asked the pharmaceutical industry, the insurance industry, and the medical device industry, all of whom would benefit under the ACA with more insured people. More insured people mean more people are going to take drugs, more people are going to have medical devices, and more people are going to have insurance. Likewise, they said to the hospital industry, help us pay for this. So the hospital industry said, okay, we'll commit $155 billion over 10 years by reducing the increase in our Medicare reimbursements each year. And then a funny thing happened. The Budget Control Act of 2011 came the next year, which cut Medicare provider payments more. And then the penalties came through the ACA for readmissions and hospital-acquired infections and other kinds of quality measures, which reduced Medicare reimbursements more for hospitals, such that since 2010, hospitals have absorbed over $100 billion in new federal budget cuts. So while the promise to hospitals was that there would be more paying customers because of the exchanges. More people would have health insurance. More people would be covered under the Medicaid expansion. That has been true for some, but less true for others. And in fact, what has been created are winners and losers for hospitals, mainly as a result of the Medicaid expansion. So you can see the top part there. In the Medicaid expansion states, average charity care per hospital is down 30%. Medicare charges are now 20% of total revenue, up from 4%, 3.5%. Self-pay charges, these are folks who don't have health insurance and are billed, they're down. Hospitals in non-expansion states, like my hospital, the University of Virginia, pretty much status quo. Uninsured still come, and self-pay charges are steady. Medicaid expansion states had a reduction of 26% in uncompensated care versus 16% in non-expansion states. An example that makes it real, the Cleveland Clinic reported a 40% drop in charity care after Ohio expanded their Medicaid program. So this is a big deal for hospitals. Something I don't have on the slide, but I'll just tell you, one of the ways they paid for the ACA, one of the many, many, many buckets of money they went after to pay for it, had to do with the bucket that reimburses safety net hospitals for caring for indigent patients. It's called the Disproportionate Fund, or the DISH funds. Because the ACA assumed more people would have health insurance through the exchanges and through the Medicaid expansion, the DISH funds are set to start declining as of 2017. So for those safety net hospitals in non-expansion states, they will not only not see expanded revenues because they haven't expanded their Medicaid, but they will receive reduced compensation through the disproportionate funds. So that is why in states like Virginia and other states that have not expanded, getting the Medicaid expansion program going is the #1 legislative priority for the State Hospital Association. Okay, what have we learned about the ACA? I'm getting a little bit towards the end here. I think our time is pretty good. So what do we know? Well, we know that getting to universal coverage will take a long time. Unlike other developed countries, the ACA invites Americans to opt in through subsidies like tax credits and penalties for not like the individual mandate, but it's a voluntary effort. We know that the low income in non-expansion states and the safety net providers in non-expansion states will fare less well than those who are in states that have expanded their Medicaid program. The 20 states that have not expanded their Medicaid program will forego $41 billion in 2016 federal monies because they're not expanding their Medicaid. Under the Medicaid expansion, the federal government is offering, through the statute, to pay 100% of those newly eligible for the first 3 years, and then it incrementally goes down to year 10, at which time the federal government will pay 90% in perpetuity. What else do we know? Well, we know that enrollment on the exchange is strongly linked to income and subsidy. 85% of Americans who purchase coverage through these exchanges, the federal or the state exchange, received a subsidy, and a sizable subsidy. 2/3 of the people using the federal exchange had incomes less than twice the poverty level. Only 16% had incomes 300 to 400%. What does that tell us? That tells us that people who are purchasing insurance on the exchanges are folks who are pretty low income and will get a fairly large subsidy. Interestingly, those of us who get health insurance at our jobs also receive a very large subsidy. We ultimately pay for our health insurance through lower wages, although most of us never recognize that. But most employers pick up about 80% of the insurance premium. So if we, those of us who have health insurance at our jobs, had to go to the exchange to buy a health insurance product, we would end up buying one that was a gold or platinum level. Employer-sponsored insurance is more generous and more comprehensive than ACA plans. All right, so this is really interesting. I want you to look at this chart. In 2010, the Congressional Budget Office projected that the enrollment on the exchanges would be 21 million through 2016. Those are the blue bars for each year. That's the growth in millions. 2 weeks ago, Sylvia Burwell, Secretary of Health and Human Services, announced that the goal for 2016 today would be a little bit less than 1 million. That is about 10 million people. That is less than half of the CBO's initial projections. The initial projections were 21 million in 2016, and the prediction now is 10 million. I think we need to ask what happened. Well, what happened is there are lots of affordability issues that perhaps the statute didn't anticipate well enough, and it includes. So you probably remember the debacle when President Obama said, if you like your health insurance, you can keep it. And that came back to bite him pretty badly politically, because what happened is, in that individual market that I was telling you about, that the ACA was designed to help fill the gaps for, that individual market was very heterogeneous. You had folks in that individual market who were young and healthy and had bare bones policy and high deductibles and didn't pay very much for health insurance. And then you had older people who didn't have health insurance through their jobs, who either couldn't get it through the individual insurance because of a pre-existing condition or paid a lot of money. And what the ACA did was standardize that to a community rating. So for a lot of people who had been accustomed to buying individual insurance at low rates, it raised their premiums by 2 and 3 times. Not happy campers. As I mentioned before, employer-sponsored insurance is much more generous than the ACA plans. ACA plans have an average deductible of $3,000 to $5,000 versus $1,300 in employer-sponsored insurance. For many people who are 400% of the federal poverty level, $46,000, that's not that much money. Buying a health insurance plan without a subsidy with a $3,000 or $5,000 deductible just feels like it's not worth it. 57% of Americans who visited the exchanges in 2015 said they did not enroll because they couldn't find an affordable plan, and 43% were not eligible for subsidies. So who are these people? We know there are 33 million people who are still uninsured. Who are they? These are the folks that the federal government right now are really trying to engage to come into the ACA. 7 million are non-citizens, undocumented immigrants. They are ineligible. They cannot go to the exchange. They cannot receive a subsidy. About 4 million people in this Medicaid gap that I told you about, they live in states that have not expanded their Medicaid and are too poor to go to the exchanges and receive a subsidy. Almost 8 million young adults. These are the folks that they thought they could capture into this risk pool. And it's really important that these folks are in the risk pool because they're mostly healthy, they're mostly young, and this cohort that will stabilize insurance premiums. Many people have said that the ACA is not healthcare reform, it's insurance reform. And it's true, it does change the way insurance works. And the way insurance works is, as I mentioned earlier, to have a large risk pool of mostly healthy people, or mostly people who do not use the service, whatever that insurance service is. When surveyed, this population says that their cutoff point, they really don't feel they can purchase insurance if they have to pay more than about $100 a month. So the $100 problem. An unsubsidized silver plan for $216, the average premium is $364. The rest of the folks are various. Some are kids that have just not signed up for Medicaid. Some are children who are in families that are caught in this family glitch. This is a very unfortunate part of the statute that if we had a Congress that could talk to each other and decided to try to fix part of the ACA instead of just repeal it, this would be a really good thing to try to fix. So the statute says that health insurance, if your health insurance provided at your job is affordable, you may not go to the exchange and receive a subsidy. By affordable, they mean 9.5% of your income or less. But here is the fine print. It's indexed to family income and the cost of an individual plan, not a family plan. So you might be a worker with 2 children and a partner, and the family plan might be $18,000 a year, and the individual plan is $6,000 a year. And as long as that individual plan is not more than 9.5% of your salary, then you and your family are ineligible to go to the exchange for a subsidy. It's a glitch. They call it the family glitch, and there are lots of people you can see caught in it, and so on. So those are the 33 million. Of those 33 million, 10.5 will qualify for exchange plans. 8 out of 10 of those 10.5 million will qualify for subsidies. Even so, CMS, Center for Medicaid and Medicare Services, estimates that only 1 in 4 will enroll. The penalty in 2016 it increases every year. This year, 2015, was $325 or 2% of income. Next year, it's $695 or 2.5% of income, whichever is higher. We will wait and see if that is enough of a stick to get people to purchase health insurance, or whether that penalty is less to them than the premiums and the deductibles. So, the politics. ACA accomplishments to date, we have 17 million previously uninsured folks who are now covered. We've eliminated discrimination in health insurance coverage by health status and by sex. It has lowered the budget deficit over 10 years. There are lots of hurdles to come. I've just gone through how difficult it is to reach out to the remaining uninsured. There is this coverage gap in the non-Medicaid states, non-Medicaid expansion states. Experts suggest that it will take at least 15 to 20 million Americans to have a stable risk pool. Right now, as I mentioned, the goal is to have 10 million in 2016. If the ACA is not able to attract healthy people into the insurance pool, it will only be a recipe for higher premiums and adverse selection. There are barriers to enrollment. Most of the uninsured are confused about subsidies. Most Americans don't understand how insurance works, particularly people who have never had insurance. 80% of the uninsured have less than $1,000 in savings. I mentioned the cost of the unsubsidized plans, and most people say they can't afford that without a subsidy. And the Republicans capture the White House and Congress. They couldn't overturn everything in the ACA, but certainly a lot of damage could be done. They could reduce the health insurance subsidies. They could abolish the individual mandate. They could get rid of the employer penalty for not offering health insurance. All of these things would destabilize insurance markets. An enduring problem for the ACA is its unpopularity. This is from Real Clear Politics. It's a compendium of many public opinion polls. This is from August. And you will see that over this time period, we still see where 48% do not approve of the Affordable Care Act, 40% do. What this tells us is just allowing uninsured people a way to get insured does not garner widespread approval from most Americans. The ACA clearly moves us towards a social insurance model where the healthy subsidize the sick, the young subsidize the old. There are definite winners and losers. Think of the previously young, healthy, insured who had cheap premiums and now don't. These insurance pools use community rating. It raises the cost for some and lowers it for others. Many Americans don't like the fact that they can't go out to the market and buy cheaper plans. People say to me all the time, why do I need, males, why do I need an insurance plan that covers maternity? I'm never going to use maternity. Because it's a social insurance model that's across the board. 2/3 of large companies say the ACA Cadillac tax, which is an excise tax that will be applied to expensive comprehensive health insurance in 2018. We can talk about that in the questions if you want me to explain that. But basically, companies will be taxed on overly generous, in their view, overly generous health insurance plans. And as a result, many large companies, including UVA and others, are paring back their benefits, increasing their deductibles in order to avoid this Cadillac tax. Employees, of course, just see it as less generous plans. If Democrats don't find a way to address the public distaste, the ACA will continue to remain vulnerable. So the ACA in context. I think we have to remember that health legislation, health policy is just one piece of our larger political system, and it really mirrors how we as Americans feel about a lot of national issues. You can see on the left in red is the opinion of conservative GOP primary voters, and on the right, Democratic. And if you look at every major policy issue right now, you will see that the electorate is completely diametrically opposed. So increasingly, we live in two different Americas, bifurcated by partisan politics. This is not the way our government is supposed to work. They often say that politics is the art of the possible, but in this environment, it's not very possible to have a lot of compromise. So with that, I will be happy to take questions as you've called them in or written them in or whatever. Thank you very much for your attention. I know that was a lot of information. No questions?
The New York Times just posted an article on October 25th that thousands who didn't file tax returns may lose their health care subsidies. Is this going to set back the ACA even further, or is that not a huge number compared to the millions who are now insured?
Right. So it's like a catch-22. People get subsidies, many of whom don't make enough money to file taxes, and yet unless they file taxes, they're not eligible for their subsidies. So the federal government, you can believe that folks in Health and Human Services and all of their lieutenants around the country are doing everything possible to get people to fill out those forms in order to keep their subsidies. The last thing the federal government wants is for the numbers on the exchanges to decline. Any other questions?
I have a question regarding that. You said that one of the most popular things is parents being able to keep their kids on for insurance. Do you have any idea what those kids look like, their profile of the kids that have chosen to stay on their parents' health insurance?
Well, all I know is that every semester I ask the students in my class how they get health insurance and how many are still on their parents' plan, and I'd say about 2/3 raise their hands. So I assume it's students who are still in school, going to professional school, to graduate school. It may be young adults who've graduated from college and are entrepreneurs. Maybe they're self-employed. They don't have health insurance offered to them at work. I think it's probably those kids.
Given that there are 20 states that have chosen not to take the Medicaid expansion and 30 that have, will it be possible to do a comparison between those two groups and see the impact?
Yes. We know already that the hospitals in the Medicaid expansion states are doing better. We know that in those states that have expanded their Medicaid programs over time, that people use more health services, and at least in Massachusetts, where this program, Obamacare, was Romney Care, and it's been going on since 2006, they have now documented that they've actually increased survival. So there are fewer deaths as a result of people having access to health insurance.
If healthcare spending continues to grow unsustainably and the aging population also continues to grow, do you think we need to, a solution could be, this may be controversial, but discouraging Americans from retiring or raising the age of eligibility for Medicare?
Right. So people bring that up quite a bit, but what we forget is if we shift people from Medicare, if we make them older, then we'll just shift them back into society. I mean, either they'll stay at their jobs and get employer-based insurance, or they'll fall into this hole. And, and if they're in Medicaid expansion states, they'll get Medicaid expansion. So it's sort of like moving the chairs on the Titanic. I think if we were talking about how to address the spending problem in our healthcare system, it's not a silver bullet, but what we need to do, and people are doing it under the ACA, we don't know yet quite how successful it will be, but we know that when we have a fee-for-service system, as we do, where physicians, hospitals, others are reimbursed for each unit of service, that provides a direct incentive to do more. The more you do, the more you get paid for. When you shift that payment model around so that you actually pay over an episode of care and you reward for disease management and coordination of care in the ambulatory sector that prevents hospitalizations, that you actually can provide services that are much more efficient. You can actually save money, and accountable care organizations are starting to do that. Some health systems like Mayo, Geisinger, Cleveland Clinic are more mature than other markets. They're seeing greater gains. It's very hard to turn that that animal around that we call our U.S. healthcare system, but the only way that we can reduce how much we spend is by changing how we pay for what we do. Okay.
Well, that concludes the webinar. Thank you all for joining us, and thank you, Professor Engelhard. I would like to encourage you all to tune in for our next webinar on November 5th with Cyril Lafon from the French Institute of Health and Medical Research in Lyon, France, as he presents translational research towards conformal treatments for prostate and the brain. Thank you.